Good morning. Thank you for joining us for our discussion about living in a COVID pandemic. It's a year after the first cases were experienced. There we go. Sorry. So it's a year after we started this, but we're still living in a pandemic, and a lot of what we'll deal with is in some gray areas. So our doctors and clinicians today will talk about those difficult areas and help answer any of your questions. So please feel free to include questions in the chat box. And let me introduce you to our panelists, and they'll take it away from there. So we have Dr. Shira Daron, and Dr. Daron is an infectious disease specialist and a healthcare epidemiologist, meaning that she helps healthcare settings, particularly hospitals, prevent and address infections in the hospital setting. We have Dr. Adam Weston, and Dr. Weston is an infectious disease specialist with Circle Health. Dr. Daron is with Tufts Medical Center. We have Emily Welsh, who is a nurse practitioner, a psychiatric nurse practitioner with Melrose Wakefield Healthcare. And we have Dr. John Wong, who is a primary care physician and also a decision scientist. So he helps people make decisions when there are complicated medical and multiple medical issues involved. So these guys are going to give you a great session. And Shira, we'll let you get started, Dr. Daron.
This is right. Tell me if that doesn't look right. Hello, and thank you for joining us. I thought I'd start us off with a quote by the famous philosopher Justin Timberlake. The gray area, the place between black and white, that's the place where life happens. And that is certainly where we've been living our lives for the past year plus. The fact is that while public health experts try to give black and white guidance, do this, don't do that, science isn't so cut and dry. And it's not just because there's still so much we don't know. It's also because different people have different priorities, different values, different risk tolerances, and that's going to affect the answers to certain questions for you. Okay. For example, should I travel to another state to see my child, grandchild, parent, etc.? While there may be a CDC recommendation you can find online to answer that question, it's really not a simple question. And that's why it's one of the most common questions that I get as an expert in infectious disease and epidemiology. I think that public health messaging is intentionally black and white. Perhaps there's a perception that people want yes or no answers, that maybe they can't handle the gray area. But I think that many of you out there can appreciate nuance, and that's why we're here today for this discussion. Now, because there are so many shades of gray, you'll also find that different scientists have different answers to some of these more nuanced questions. And that's not because they aren't being honest with you, or because they don't know what they're talking about. It's because when it comes to things like pandemic management, there are as many ways to skin the cat as there are experts. Adam, John, Emily, and I might not agree completely on things like school reopening, the concept of eliminating COVID or zero COVID versus flattening the curve, the question of whether or when we will reach herd immunity, what we can do safely post-vaccination, and whether we're heading into a fourth wave. But that's why we have respectful academic discourse, and we're capable of having that kind of conversation on these topics. We invite you into our professor's lounge, so to speak, where we'll discuss complicated, nuanced questions about COVID-19 with honesty and transparency. So let's start with a tough one, why not? People are confused by the numbers. Should they feel hopeful or anxious? Are we headed into a fourth surge, third surge in Massachusetts, or are we vaccinating fast enough? Are public health officials messaging the right levels of doom versus optimism? Is it dangerous to message optimism? Adam, what are your thoughts?
It's a little bit of both. And I personally, I vacillate day by day, hour by hour. So I hear about increasing vaccination within our community, with our country, in our local town. We're doing an even a better job, and that makes me very hopeful that we are seeing a very large light at the end of this very dark tunnel. And then I hear about despite all of this, the numbers are starting to creep back up, and we see people that have become a little bit more lax in their behavior than we would like them to at this stage. And so dealing with human behavior is very difficult. And so it is one of those things that you can almost keep a contradictory statement in your head at the same time. That yes, I am very hopeful, but this is the first time we've been on offense against this virus with vaccinations, but yet we still have this virus here, and it's not going away as fast as I would really like it to. And so, but we do have hope. I think that is something that I try and cling to, is that, we are making progress. We are getting better. And we certainly are, even compared to, a month and a half ago, 2 months ago, we are substantially better. We're just not quite to where we all, I think, really want to be. And I think that's the frustrating thing, is that I think we were all hoping that we'd be like, all right, COVID's gone now. And it's really, as we've all discovered with COVID, nothing is as simple as it seems, unfortunately.
Yeah, I'm going to turn it to John in a second to talk about predictions and modeling, but I think that we're really on a precipice, and I think that we could go either way here in the Northeast. And I think that we know from other countries, and even from our own country, especially Michigan right now, that we're vaccinating as fast as we can, and we may or may not be vaccinating fast enough. And I think it's okay to message optimism or realism, because while we may see an increase in cases before we see a decrease, I believe that based on the experience in the UK and in Israel, where they're ahead of us by weeks with vaccination, they're seeing incredible results. John, what are your thoughts?
Thanks, Shira. For the past year, I've been looking at the pandemic, both worldwide in the United States and locally within Massachusetts, and in particular predicting the course of the virus for the implications for our hospitals to prepare. And I'll just say, relative to the three main hotspots around the world, which are Brazil, India, and Europe, as a country, we're doing better. The worrisome thing is our case rates have risen up to about 72,000 per day, an uptick over the past month, presumably due to the variant. Taking things more locally to Massachusetts, we had seen declining confirmed positive cases up until around March 10th. And since then, we've seen a steady increase of roughly about 17 confirmed cases per day since March 10th on average, when you look at the 7-day average. And then what I tend to think or worry about are the hospitalizations, and in particular, the intensive care unit cases. And what we've seen there is similar to the confirmed cases, a decline over the past few months up until March 22nd, or roughly about 12 days after we started to see a rise in the confirmed cases. And since then, we've seen an uptick of about 7 hospitalizations per day when you look at the 7-day average of hospitalizations. The silver lining in this is exactly what Adam was speaking about in terms of vaccinations. And so to put this in context, I want to talk about the average age of cases, hospitalizations, and deaths. And vaccinations have been occurring in increasing rates in Massachusetts since the beginning of January. And I want to contrast the average age of cases in January, which at that time was an average age of 41. And it has dropped to 34 since then. And then I want to contrast that with the average age of hospitalizations, which was 73 at the beginning of January, and that's dropped to age 61. And for me, that's a direct effect of our vaccination, where the strategy has been in Massachusetts to vaccinate those who are most vulnerable to the infection, which are the elderly. And as a consequence of that, we see a marked drop in both the average age of cases as well as hospitalizations, but especially in the average age of deaths from 81 now down to 76. So we've seen an average drop of 5 to 8 years, But in particular, there's this contrast between the average age of cases, which is relatively young, the average age of hospitalizations, which are roughly about 30 years older, and the average age of deaths, which are roughly about 20 years older. So this is clearly a virus that impacts the most vulnerable and the elderly. Having said that, it can also obviously lead to hospitalizations in those who are younger. And any of these hospitalizations, any of these ICU stays, any of these ventilator use, as well as the mortality, are tragic. And my view of where we are right now is we're at a corner, an inflection point. And it's a race between the vaccine protecting us, worry about the variants of concern, in particular the UK variant and the California variant within Massachusetts. And then, as Adam and Shira mentioned, human behavior. What are we going to do about masking? What are we going to do about physical distancing? We know that this virus knows no geographic bounds. And so our main weapons are vaccines and these safety measures, masking, wearing a mask, watching your distance, washing your hands. And then the three that I like are avoiding crowds, enclosed spaces, and close contact.
I'm going to turn it over to Emily in a moment, but I also did get a message that because we had sound issues in the beginning, the intros may have been lost. So I want to tell people that Dr. John Wong is a physician in primary care here at Tufts Medical Center, and he's a decision scientist who's been doing a lot of modeling and projections related to COVID-19 and the pandemic. I'm going to ask Emily a question. Emily is a nurse practitioner in psychiatry at Melrose Wakefield. Emily, given what John just said, and given all of the uncertainty and associated stress and anxiety about where we're headed, do we need more optimism? Is optimism dangerous? John just said we still need people to do the right thing, to follow the mitigation measures, to wear their mask. Is the optimism over vaccines, is it going to lead to behaviors that might push us in the wrong direction, or do we need it? But then if reality ends up being worse than the predictions, what will that do to people emotionally?
That's a great question. In mental health, we know that optimism improves both physical and mental health outcomes. So there's nothing bad about optimism, no matter what happens. It's going to be important to remain optimistic throughout this. It's natural to have anxiety or fear when there's uncertainty. One of my favorite quotes by Marie Curie is that nothing in life is to be feared. It's only to be understood. And throughout the past year or more now, we've learned so much about this virus. People need to stay informed about what's going on. To decrease anxiety, make sure that you're getting your information from correct sources, such as the Department of Public Health or the CDC. Try to avoid Dr. Google at all costs. In helping to stay optimistic, it can be helpful to have some strategies to manage anxiety and uncertainty as well. One of the most simple strategies is just when you're feeling overwhelmed or anxious, dropping what you're doing and just taking 5 long, deep inhalations and exhalations. You can build in some mindfulness techniques, trying to focus on your 5 senses, what's going on in the moment, what you're smelling, seeing, feeling, tasting. And after you do those 5 deep breaths, you tend to feel a lot better. Like Dr. Wong said, there's always a silver lining in everything. Try to think back over the past year if there's something that stood out to you that was positive, or something that you persevered throughout this pandemic. And we can all think of something because we all went through this together.
So speaking of anxiety, we have a question in the chat about something that we did want to bring up. Today, the FDA and the CDC released information asking for a pause in the distribution of the J&J vaccine while they investigate the implications associated with 6 cases of blood clots, and they were cerebral blood clots in the veins of the brain, one of which was associated with a fatality. One of the patients is in the ICU. All of the cases occurred in women between age 18 and 48. All of these events occurred between day 6 and 13 after receiving the vaccine. Again, because some of you missed the introductions, my name is Shira Daron. I'm an infectious disease physician at Tufts Medical Center and a healthcare epidemiologist. Adam Weston is here from Lowell General. He's an infectious disease physician. Adam, what would you say to someone who asks, I got the J&J vaccine on Saturday, and I actually have an underlying clotting disorder? How would you advise this person?
So I think the best advice we can give right now is close monitoring. If you develop, the CDC put out, recommendations to say, all right, if you have any of these symptoms that might be concerning, such as headache, leg pain, trouble breathing, things like that, you should contact your doctor immediately. I think one thing that we all need to keep in mind is that this is still in the we're not sure what's going on phase right now. That's exactly what the FDA said, is we're going to investigate. We've had these cases, these are serious events, right? And we need to look and say, all right, is there any kind of causal association with them? Which is exactly what they're doing right now. So I think kind of close monitoring. These are very, very, very rare events. So they documented 6 of these cases. We've given over 8 million doses of Johnson & Johnson in this country alone. And so even if we do determine that there is some kind of causal relationship between these things, although these things do happen for many other reasons, so that's what we're trying to kind of figure out, is there something that was truly associated with this vaccine or not? But even if there is, it's still an extremely rare event, so literally 1 in a million. And so while that is scary and upsetting, and the people that get it, it's extremely serious, COVID is still way worse. Even if we gave it to every single person in the entire country, we'd be talking 300 or 400 cases of it, which would be bad, but more people died from COVID in this country yesterday. So it's I try and keep things in perspective when I talk about these things. That yes, this is scary, but COVID is scarier than almost anything we have on the table right now.
Right,
And
so this is an infographic that was created by someone else that speaks to exactly what Adam is saying. This one was created for the AstraZeneca vaccine, actually, which saw a similar phenomenon in terms of blood clots. In this case, with the AstraZeneca vaccine, the cases were 4 in a million. At this point with the J&J vaccine, we're talking 1 in a million. So an even smaller percentage affected than what you see here. But if you talk about a 0.0004 or less risk of blood clot associated with vaccination, some of the things that people do on a daily basis, like taking birth control pills, which have been deemed to be a reasonable risk, are more along the lines of 0.05 to 0.12% risk of blood clot. Smoking carries a 0.18% risk of blood clot. COVID infection carries a 16.5% risk of blood clot. And right now, with COVID being so prevalent in our community still, that does need to be kept in mind. While we're on the topic of vaccine, there's a lot of discussion, a very black and white discussion, I would say, about the different vaccines and their efficacy. And one of the key messages that we've been hearing over the past several weeks is you should take the first vaccine that's offered to you, which I think we all agree with. But what's sort of more gray is this question of, are they all the same? Are they all associated with the same efficacy? John, do you want to tackle that one first?
I'd be happy to. I've taken a very careful look at the 3 vaccines that have been approved within the United States. And a lot of people focus on the efficacy related to preventing infection for the 2 mRNA vaccines versus the J&J version. And I'll just say that when you compare those 2 numbers, you're not comparing apples to apples. And the reason for that is the studies that were carefully done in tens of thousands of patients for the mRNA vaccines were done at an earlier time in the pandemic, whereas the J&J vaccine was tested at a later time, including sites in South Africa, Brazil, and as a result of that, some of the variants of concern that are now circulating around the globe were involved in their study population. So when you look at that prevention of infection, you have to keep in mind that the variants of concern have a higher rate of transmissibility and contagiousness. And consequently, it's not an apples to apples comparison when you're looking at the time at which the studies were done. And perhaps more important than preventing infection is, I think as we all agree, trying to keep people out of the hospital, and most importantly, trying to keep them from dying. And we know that all three of those vaccines are highly effective at preventing serious infections that lead to hospitalizations and, most importantly, to mortality.
The way I think about it is kind of, what are you asking the vaccine to do? And so I think, everyone would like to prevent all COVID all the time. Like, we want these things to be 100% effective to prevent any and all COVID ever, right? Which would be great, but that doesn't exist. But what we're asking the vaccine to do is to kind of keep you out of the hospital and keep you from dying. Like, it'd be nice to not get COVID at all, but like not getting you in the hospital and needing kind of all that stuff and having severe COVID and dying is kind of the most important thing. So I think we do have to have a certain amount of honesty that even if you look at the US numbers for the Johnson & Johnson vaccine, that we didn't think there was a lot of circulating variants for that, it's still not quite as good at preventing any and all COVID compared to the mRNA vaccine. It's roughly about 72% versus 94, 95%, right? But where we really want it to do, what we really want it to do is keep you out of the hospital and keep you from dying. And in that case, they do seem to be all very similarly effective. The analogy I make is, you're commuting to work and you have your choice between, your reliable Honda Accord and your BMW, right? They're both going to get you there. One's going to make you make a little bit more comfortable, but they're both going to do the job you're asking them to do. And that's kind of where I kind of come down. Because right now, particularly given the scarcity of vaccine, I think that's where a lot of this messaging comes from. If we had all the vaccine ever that we could ever want ever, yeah, we could put up a menu and you can say, no, I want, Pfizer. But we're just simply not in that situation right now where people have the ability to choose because we have so little to begin with. So any vaccine is a good vaccine right now.
I think that's right. I think if you were to actually do a head-to-head clinical trial, as we say, as the gold standard for comparing two things, we might find that the J&J was less effective at preventing the mild infection, which is not really what's important here, than the mRNA vaccines. We might also be surprised and find that they were more equivalent than we think. I think we just really don't know. So talking about vaccines, there's a lot out there right now about what can you do after you're vaccinated. And I think, maybe I'll have Emily kick it off a little bit, because part of this is about how important some of the things are that we've been putting off, how lonely people are, how much they need human interaction, how much they need to see their loved ones. And again, the CDC has put some very black and white guidance out there. If you're not particularly vulnerable and you're vaccinated, you can see your unvaccinated family, but only one household. And we'd prefer you not travel to get there. So Emily, how much is our population suffering right now because of what they're being asked not to do in the name of keeping the pandemic under control? And then maybe we'll discuss a little bit why the recommendations are as they are.
Sure. So we've really learned a lot about how social isolation affects mental health, and it really is not good for mental health. We've learned a tremendous amount about how much the pandemic can increase social isolation, and we've learned a lot about how bad that can be for our mental health. It's going to be really important that people still make a strong effort to connect with others and find out what other people's comfort levels are around you or in your social network. It's still going to be really important to follow the precautions of masking and social distancing for quite some time. We don't know how long that will last, but until there's enough people vaccinated, it's safe to say it's going to be in place for a while. Try to reach out to a neighbor or someone that you care about, even if it's just starting with over the phone. Talk to friends and loved ones about what their comfort levels are. Some people may feel comfortable only getting together outside. You may want to take the risk of indoor dining, but stick to, the first seating before other people are in and out of the restaurant. Or sticking to outdoor dining as things get nicer outside. If you're not feeling comfortable kind of putting yourself out there just yet, still try to do things that are going to increase and help your own mental health and well-being, such as exercise, especially getting outside in nature to exercise, getting enough sleep, and eating well. Those are all things that are going to help your physical health in the long run if you do come into contact with COVID. Another thing is to challenge anxious thoughts and worries. Cognitive behavioral therapy can be helpful in kind of challenging automatic negative thoughts that can come up, especially when we think about maybe traveling in the future or going back to school. Sometimes those anxious fears can start to really bubble up, and you need to take some time to intervene. If you're having a negative thought, try to challenge what is the reality behind it, and then replace it with a positive thought. And sometimes it takes practice doing that.
Some of the things that I advise people to do when they ask the question that I've probably been asked 1,000 times over the past year is, should I do this or that? Whether or not they've been vaccinated or not, that's been a constant question. And the way I think about it is this: there's your own self-preservation. There's the risk to you, which to some extent is your personal choice, how much risk you want to take. But to some extent it's not, because if you get sick and you take up a hospital bed or an ICU bed, that does affect others. If you get sick and you pass it on to someone else, that definitely affects others. So you do have to think about it all in that context. Now, if you're vaccinated, you're very, very unlikely to take up a hospital bed or an ICU bed, unless you have underlying medical conditions, immune compromising conditions, not studied in the clinical trials, that would make you less likely to respond to vaccination. So for most people who are vaccinated, they're not going to get very sick, which is why the CDC has said that they can be with unvaccinated people, which is why the CDC has said that it is safe for them to travel. Nevertheless, they are saying that they don't want anyone to travel right now. And I think that's part of their desire for black and white messaging that targets everyone in the country all at once, as opposed to having specific messaging for different parts of the country and different populations. I think when it comes to things that are going to pose risks to others, unvaccinated people doing risky things, especially people who live in a home with a lot of other people, those people are vulnerable, especially people who do things in larger groups, schools, congregate settings, et cetera, that really changes that risk calculation too. I think one thing though that has been really critical to this conversation is all of the data that are coming out that suggest that vaccinated people are not likely to become asymptomatic carriers and transmit it to someone else. So that's a really key piece of the conversation over the past few weeks. John, Adam, anything to add to that?
I was to say, I think I get asked the same question a dozen times, and the thing that I often come back is, well, what does everyone else in the group think? Because it's kind of a, if you're kind of planning some kind of group activity, whatever it is, it's kind of a group decision. You all have to kind of find your compromise of where your risk tolerance is, because there is no clear right or wrong answer in these situations. Are you going to do an all outdoor Thanksgiving? Are you going to do an all indoor Easter? And so there's kind of, as we say, a huge gray area of kind of, these things are kind of probably okay, but there's some that are on the slightly more riskier side, and there's some that are on the less riskier side. Kind of, you have to figure out where everyone else in the group kind of falls. And so it's not just you, it's the whole, community that you're interacting with.
Yeah, I'll just add that there are a few things that we have that are under our control with regard to exposure to the virus. And we know that it is spread by contact. And so we have vaccination, which we spoke a little bit about. And I just want to add, there's a lot of misinformation about the vaccines. There's also some disinformation trying to discourage you from getting the vaccine. And if we can't possibly address all those questions on this, but again, you will, in all likelihood, have a trusted primary care provider, and I would encourage you to reach out to that clinician to help answer any concerns or questions you may have about the misinformation or disinformation. The other piece I think about in terms of things that are under your control that are on an individual level have to do with your risk tolerance and the value of that personal contact to yourself. So I care for some grandparents who are more than happy now to accept that there may be a little slight risk to hugging their grandchildren. But you know, it's been a year like no other year for these grandparents who've sort of missed a year in the development of their grandchildren, whatever the age of those grandchildren are. And you know, getting vaccinated, and then you can make some decisions about mask or no masks. My wife's a musician. They're starting to perform in groups again, and as a group, they decide about masking and about whether or not to test before gathering together or test afterwards, just as Adam mentioned. And you know, for me, this is that gray area. How important is that travel for you? How important is that hug from your grandchild? And then how important is it for your own safety, and how much do you worry about potentially spreading the infection to others?
So part of what makes it so confusing is that at a policy level, at an epidemiologic level, it's not always been clear what we're trying to achieve here, right? In New Zealand, they go for COVID-0. One case causes a lockdown. And here we seem to be, first of all, doing different things based on what state you're in. And second of all, kind of vacillating between, are we trying to eliminate it? Are we trying to flatten the curve, which was a phrase that was meant to say that our goal was to make sure that the hospitals weren't overwhelmed, but aside from that, it was acceptable to have some degree of COVID in the community. And since we've never established that, what our goal is with COVID, it really makes it hard for the individual, right, and the groups that you talked about, Adam, to figure out what they're supposed to do to be responsible. John, how do you address that? What do you think our goals are here?
They're the goals we have as a country. And unfortunately, from a public health standpoint, this pandemic has been politicized. And as a result of that, we don't have a national coordinated strategy and approach. At least we had not over the prior 4 years. And I'll just say from a New Zealand perspective and an Australia perspective, it's really helpful to be an island and to be able to restrict air travel in and out of your country. Because again, this virus knows no boundaries, yet you need somebody who's infected to enter your space. And for me, that's part of the concern about, on the CDC's part about essential travel. You worry the most about traveling from a high prevalence area to a low prevalence area. And in terms of individual decision-making, which we were just talking about, you know, you really have to think a lot about the context, who you're coming in contact with, what are their behaviors likely to be, and again, is the risk of exposure worth the risk of, or the benefit to you? And so air travel is one for me. I think being on an airplane where everybody's masked is actually not very risky. What I do worry about is getting from your home to the airport. In terms of your fundamental question though, Cher, in terms of, you know, do we flatten the curve or are we trying to eliminate it? I think elimination would be very difficult for our country given the politicization. And so flattening the curve is really important because we never want to get into surge capacity where we have to institute these critical care standards where you're placing healthcare clinicians in a very difficult position where they're trying or having, by necessity, to make decisions that we never want to make in other circumstances. So flattening the curve is a key piece, especially early on in the pandemic where, we saw what happened in New York City, for example. We did not want to see that happen in any other place within the United States.
I think that's one thing that is, we may have to accept that we're going to have to live with COVID. Right? We talk about like, oh, when COVID's gone, we'll go back to normal, right? We may not get back to 100% normal. We may come to kind of a certain equilibrium with COVID, and that we accept the flu every year in a similar way, not to equate them in any way, shape, or form. Clearly, COVID is a more serious issue, but if we get to a certain level of immunity within the general population, like John said, it may not be enough to kind of completely eradicate COVID, but it may be a much smaller problem in the grand scheme of things. And therefore we can start kind of pulling things back, kind of approaching some level of normal, but COVID may not ever kind of go away. And I think that not only is it an issue with the United States of that we have 50 different kind of states doing 50 different things, we now have 200 odd countries doing different things, and COVID is a global problem, not just a local problem. And so even if we somehow manage to get COVID under control, then India is still having issues, Brazil is still having issues, and so it's kind of a longer term issue. And I think that can be very tough because people are like, when is this going to be over? Right? When am I going to be done with this stuff? And to tell them to tell people like maybe never is a tough thing to say, but that's kind of, we may have to kind of learn to live with it.
John talked about the politicization of COVID, of the pandemic, and Adam, you talked about needing to live with it, and Emily, you've talked about the harms that come from some of the mitigation measures that we've had to follow during the pandemic, and nowhere is that more true than in our schools and for our school children. I think that there was an issue when the President Trump at the time said that schools should be open. And there were many people in this country that sort of felt that anything that that president said was automatically the opposite of how they felt. That is part of the reason that many schools have remained closed for as long as they have. Many schools, if they've opened, have opened in a hybrid status. The equity issue has been enormous. Private schools have been, for the most part, open full time. Schools in more affluent areas have had more in-person school than schools in less affluent areas. Remote school, because it involves computers and internet, just by definition, is going to affect children of lower socioeconomic status more. Emily, what is your feeling about schooling, about the current state in terms of the weighing those risks and balances, risks and benefits of schools being open, bringing more children into the building, say for this rest of this year, which the Massachusetts governor and commissioner of education has said has become the top priority and is to happen, and in terms of what it looks like for next year.
So families need to continue to make informed decisions and think about what's best for their family in particular. For some parents, they're dying to get their kids back to school, and they need that in order to provide financially or to preserve their own mental health if they're balancing childcare and working from home as well. It also can be a learning opportunity for children, and this is only going to build resilience in children as well. Learning how to cope with stress helps them as an adult. If they're able to implement coping strategies to manage anxiety while they're young, it's only going to help them that much more in the future. It's also a great way for parents to educate their kids about infection control, washing hands, learning how to use a mask. And we don't know what the future is going to look like, but we're all resilient as human beings. I think we can look to other countries that have gone through epidemics. We know this is not the world's first pandemic. We may get to a point where, Japan or China have been a number of times before and evolve culturally and as a community and understand that maybe we need to put a mask on if we're not feeling well, or just to be respectful of someone else if you're in a crowded area. We can all kind of learn together throughout this. And same thing with going back to schools as well. But do what your family's comfortable with, stay informed, and then weigh that risk benefit ratio and do what's right for your family.
John, do you have some thoughts on the epidemiology of schools and COVID?
Yeah, early on in the pandemic, there was fear, uncertainty, and doubt, especially with all the tragic events that we witnessed on television with regard to the pandemic. And there was a concern that this pandemic might be similar to, as Adam said, influenza in the sense of contagiousness, where children would get influenza and then bring it into the household and spread it among family members. And we have since learned over the past year that the infection is, for the most part, relatively mild, much milder, much less likely to lead to severe consequences in children. That's not to minimize the few hundreds of children who have died from COVID, nor are concerned about multi-inflammatory system disorders. But you're trying to sort of weigh that against sort of, well, what's happening because we've closed schools, now that we know that there's the infection is of lower risk. Well, there are the educational goals that might not have been achieved, especially with regard to equity. There's the food insecurity of families, and now unfortunately emerging are the housing insecurity that's associated with that. And then on top of that, there's this sort of lost year potentially of education. And what we know now over the past year is that from studies in the UK, from studies in the United States, that if you adhere to a set of precautions, the risk is quite low in terms of the infection rate for the children as well as for the staff. And I know that there are many teachers who would much rather be in classroom with children, dealing with them, as opposed to having to develop Zoom curricula. They, like the children, miss that social interaction as well as the educational opportunity. And families will, as you said, have to make sort of that choice between do you keep your child remote or do you let them go back to the classroom? And there are videos obviously of children who've been out of the classroom for a year who are just thrilled that they'll be going back.
I agree with that, and I think that we have some pretty good data here in Massachusetts, and other states have it as well. It's the case investigation data, they call the reverse contact tracing data, that generally week after week have shown that in settings where there are rules, in settings where there are eyes on people that are not private homes, that are not small gatherings, that are not households, the risk of transmission is less. We do know how to prevent it. When we use masks and distancing and, decent disinfection and decent hand hygiene and decent ventilation, but you don't need every single one of those things to be perfect because each of those is layers. But when you use that, transmission is actually quite rare. The vast, vast majority of transmission is happening in households, in your home, which unfortunately is relatively unavoidable. But settings like schools, retail, even gyms and restaurants are way, way less common for transmission. And especially the social emotional aspect of closed schools concerns me a lot. The number of children that are waiting for psychiatric beds, the number of suicide attempts and admissions for suicidal ideation are really concerning to me. And so I am a proponent of the governor and the commissioner of education's plan to move ahead with the deadlines for full reopening of the public schools, and the elementary deadline already passed, and so far so good with that. So when we think about, say, next school year, when we think about even the summer and the fall, what does that look like? What do we think is the future of masks? If you were the governor, Adam, when would you drop the mask mandate, or would you drop it, or what would it look like?
That was a very good question, and if I had a crystal ball, I wouldn't be here because I would have won the lottery already. But so the best I can do is guess, but I can see a future in which there's very low levels of COVID in the community. So yes, it's not completely gone, but it's extremely low amounts, and total case numbers are very low. You could see a pulling back of some of our restrictions. So, you know, keeping maybe masks for kind of high risk, close contact indoor spaces, but, you know, these less risky spaces, you know, we start pulling things back. We can maybe, you know, these broader spaces, certainly outdoors, is the easy thing to pull back, but in kind of these higher close contact spaces, maybe keeping it there. You know, in healthcare settings, it's probably reasonable to kind of keep it for a little bit longer than average. Will it ever go away entirely? I'm not sure. I could see a future in which mask wearing becomes a little bit more, in certain, at least in certain areas of the country, a little bit more societally acceptable, particularly during kind of cold and flu season. You know, you look at kind of some of our Asian counterparts that have a long history of culturally wearing masks during cold and flu season, and they did much better with COVID than we did. And so you could see a future, you know, even without COVID, you know, this year we basically had no flu. We had like almost zero flu, which is amazing. And it turns out that to just make flu go away, we all had to wear masks and stay 6 feet away from each other. And that's 30 to 60,000 people in the US alone that die from the flu prior to this year. So there's an argument to be made that kind of during cold flu season, you know, maybe we should be wearing masks kind of more in general, just kind of as a courtesy to all of our fellow human beings. So we don't get people sick as much. I would like my son to not come home with a cold from daycare like every 3 weeks. I mean, he's had like one cold this entire year. It's been fabulous. So it's guesstimating at best, but I can see a future in which masks become much less prevalent. But I suspect there's going to be some level of masking in some certain situations, in certain times that are going to be still appropriate and advocated for.
I think that we know that the risk is very small outside. I think we kind of knew that when the full mask mandate went into effect from Governor Baker, that we need to mask even outside. And I think part of that was because of other people's comfort, not true science. I think that the health departments were getting a lot of calls from people saying, I was outside and someone wasn't wearing a mask and they came within 6 feet of me. So I think it's going to be a tough one. You know, I think that the outside is the first place that should go, but I'm not sure how people will feel about that. I like that we've sort of begun to message that masks don't just protect others, they protect you. And so I think people have more of a feeling, would you agree, Emily, that they're in control of their own safety, that other people's masking isn't as important anymore for their own safety because they can control their own safety. But I think we might need to start messaging that even more. We're coming up on the end of the hour. I thought maybe we could go around and just kind of finish with the idea that as scientists, we are constantly learning new information and adjusting our recommendations, and never has this been more true. And we can just go around in a minute or so, and can everyone tell me either kind of what their first thoughts were when this pandemic hit, or what they were wrong about that they've learned and changed their tune about, or something unexpected that has happened to you as a scientist during this pandemic? Just let's share some stories. Adam.
Sure, I can say way back when, so kind of January of 2020, I didn't think COVID was going to be a big deal. Clearly, I was very wrong on that one. But you know, I looked at kind of how things were being managed in China, the numbers there, and I said, oh, you know, they seem to kind of have it fairly much under control. It didn't, you know, it was 100,000 cases, but that's, you know, okay. Even if it was 10 times worse than the U.S., it's not going to be that big of a deal. So I was definitely very much wrong on that. I think we've all been playing catch up since, but I think the speed in which data came out, particularly early on, or lack of data early on, I think kept us all very much on our toes. I was writing new policies on a basically daily level early on in this whole thing. So it was, I think everyone was feeling the frustration that we just didn't know, and we were just trying to kind of do our best with the limited information that we got, and we got some kind of additional information. Then at one point when I found out, you know, there was a study that they had a higher proportion of asymptomatic spread, and I was like, whoa, if that's true, we're in trouble. Turns out it was true, and we were in trouble. So I think we all learned a lot. And
that was the game changer for sure.
Exactly.
Emily?
So for me, I think, you know, with the mental health perspective was learning that I am no different from everybody else. You know, when this first started, I would go to work and, you know, try to reassure others, especially patients that were coming in. And, you know, COVID and this whole pandemic was kind of the last straw for them. You know, maybe put some people over the edge where they were feeling very hopeless and needed more support. But then me recognizing that I really needed more support as well. When this first started, I remember I was going home, you know, changing out the door before I go in. My husband and I were debating whether or not I should leave the house while this whole pandemic took place. And, you know, when I look back now, you know, I was anxious about it, you know, so learning how to manage my own anxiety, but still be able to provide support for others was a huge learning experience. And knowing that we're all in this together, and we still are.
Definitely. John, how about you?
Yeah, so very much touch on a couple of themes. One is the original SARS back in 2003 was quite limited, and we were able to extinguish that pretty quickly because, as Adam somewhat said, you know, you were only contagious back in 2003 if you were symptomatic. And we thought that might apply to this second version of coronavirus. And the game changer for me, as for Adam, was, gosh, this can be spread a couple of days, 2 or 3 days before you become symptomatic. And then maybe for 2 or 3 days before you become symptomatic enough to get a test or to seek medical attention to get a test. So there's this sort of period where people are fairly contagious, and as a consequence of that can spread to other individuals. And as you know, I like evidence-based medicine, and early on in the pandemic, there was very sort of limited evidence that masking would help, but we didn't know about this asymptomatic spread, and we learned, and as a consequence, we can control the infection. And asked about the future. Well, I can see a future where, at least in a hospital where we have universal blood precautions, where at least temporarily we're going to have masks probably universally within hospitals, just because that's where the sickest patients may end up. And the other key piece is we were hoping that with warmer weather, the virus would go down, and that was not the case. And then lastly, for me, most importantly, you know, a year of being a physician and seeing the pandemic go through our hospital, go through our population, and a year in which we've minimized physical social contact, at least for us in the health profession, it's given a chance for what we've trained for, what we've wanted to do for all our lives. And in particular, our infectious disease physicians such as yourself have helped lead the way in terms of how to control, handle, manage our fears, uncertainty, and our doubt. And I thank you for that, Shira.
Thank you. And I'll just end by saying that for me, I thought that we all had to get it, or 70 or 80% of us would have to get it for this to be over. I thought that the only way to get to herd immunity would be for a lot of us to become infected. And I never imagined that we would have vaccines with such high efficacy. And in less than a year, I think, you could have knocked me over with a feather when I learned that the first vaccine had 95% efficacy. And, we did keep people alive, not enough. We lost a lot, but we did stretch this thing out until vaccines and new therapies were available. And in doing so, we did save lives. So I think I'll close with that. And Brooke, I don't know if you want to take us out.
Yeah, thank you for everybody for joining today. And this will be posted on the pages if you want to share it with friends and family. And feel free to post your questions on our Facebook page as normal, and we'll get back to you. So thank you all speakers for giving some great information today.